Right, everybody, let's take it away.
Good evening and welcome to the 56th virtual shadowing session. My name is Kiana Hunt and I will be hosting this session tonight. Tonight's session focuses on trauma and emergency medicine, and this session will be presented by Dr. Reno, Dr. Fowler, and Dr. Marchetti, our leading physicians. As always, if you have any questions or concerns, feel free to reach out at virtualshadowing@gmail.com. Also, make sure to check out our Instagram and join our mailing list in order to be informed about future sessions. Next slide, please. Here is our virtual shadowing team, which consists of Reagan, Cheyenne, Taylor, Ali, Rachel, Miriam, Elena, and Ruth, Rohit, myself, and Aditya. We also have our leading physicians, Dr. Fowler, Dr. Marchetti, Dr. Reno, and Dr. Salazar. Next slide. We have a very busy week, but it consists of some awesome sessions. Tomorrow we will have a PA student panel at 7:30 Central Standard Time. And then on Thursday, we will have a PA spotlight focusing on orthopedic surgery. Then the following Tuesday, we will have a nursing spotlight focusing on med-surg. If you're unable to make any of these sessions, they'll be recorded and posted on our YouTube channel. Just make a note that the PA student panel will start at 7:30 Central Standard Time, but the other sessions will start at 7 p.m. Central Standard Time as normal. Next slide. And then we'll have 2 Q&A sessions as normal, one in the beginning and one at the very end. Make sure to put all of your questions in the chat box as we go along. And before I hand it off to Dr. Marchetti, make sure to turn off your cameras. Dr. Marchetti has some awesome videos in his presentation, and he wants to make sure that we have the best quality. So without further ado, I'll hand it over to Dr. Marchetti.
Thank you, madam. Yeah, we'll see how it goes, with the internet bandwidth and all. It just depends on, the Zoom universe, if it wants to cooperate or not. So you guys get the privilege, I guess, of hearing, Dr. Fowler and us kind of lead you through a few cases that come from our own personal experiences. And I know you guys often ask about trauma and a lot of other questions related to it. And so, prepare for a little bit of kind of blood and gore and shock and awe tonight. As far as we'll go through. I'm going to go first, and then Dr. Fowler will go with his case. Dr. Reno will finish up with hers, but you guys can ask any questions at any time of any of us. But Dr. Fowler's and Dr. Reno's cases will come after the first Q&A. So for the first part of the session here, we wanted to cover a lot of the most common questions asked. And although, for this question here, the how do you stay calm during an emergency? The simplest answer would be to say, I don't know, we just do. But that's not really fair to you guys. So we're actually going to talk about this for a minute. So first, let me start out by saying that there's a reason that our medical training is so freaking long before you're actually allowed to start practicing on your own or supervising the clinical care that's provided by others. It takes thousands and thousands of cases of repetition to even begin to know what you're doing. And no one expects you to really learn how to stay calm from the beginning. So that being said, it just comes more naturally to some people. And those individuals, ironically, are usually drawn to specialties that are surrounded by chaos and death and carnage. So we'll kind of go around the horn here with all the docs and give you some of our own tips. So if you think that just because we're physicians that we're somehow just innately wired to remain calm in an emergency, I'll tell you that's garbage. Next time you're on a plane and someone starts choking or has a seizure or goes into cardiac arrest and they ask for a doctor on the plane, just watch the fear and trembling in the ophthalmologist's eyes as he tries to step in and help. When I was an intern, I distinctly remember one of my faculty giving me an evaluation that it said something along the lines of like, when all hell's breaking loose in the ER, that I was like a duck. What she meant was that I appeared calm and cool and collected and, everything on the outside, but she knew my feet were paddling like hell under the surface of the water. And it took me a while to understand that that was actually a compliment. I was very confused for a while about that. But she knew that I was working hard and fast and furious and multitasking and, commanding the room during resuscitation. And I did so in a manner that on the outside tried to put everyone else at ease, and that even if I didn't, I at least looked like I knew what I was doing, even if I wasn't so sure on the inside.
Yeah, but Brandon, you were a medic in the field in a previous life. Don't you think that maybe that helped prepare you to be calm?
Yeah, absolutely. Lots of times of, puckering up the sphincter and, freaking out over calls teaches you how to be a little bit more calm and relaxed. Everyone has their tricks for how to stay calm in emergencies. And I'm certainly not advocating for you to mentally escape to your happy place during an emergency. Like Dr. Fowler said, for me, it was a little bit easier because when I started my career as a physician in training, I had already been a paramedic for 12 years, responding to and managing emergencies. So that did help, but it still took years to develop that. And when you constantly practice like you play and play like you practice, it then becomes natural. You learn how to drown out the noise and focus on the important elements. You can kind of utilize all your senses to collect and synthesize information simultaneously. All of your technical skills, the cognitive demands, they can easily overwhelm you if you're not careful. You just learn how to stay organized and collected in your mind. And then that turns into organized and collected actions. I once heard a joke that, a physician, we have to take all these crazy hard math classes during our prerequisite years, advanced calculus and so on and so forth. In reality, all you needed to learn to be a successful emergency medicine or trauma physician was how to add two simple numbers together, but you got to do it while everyone's running around the room screaming and the room is on fire and people are trying to die. That's the doctor that you want taking care of you. So, Dr. Reno, we'll start with you. What are your tips and tricks for how you stay calm during an emergency?
I think it's a learned skill. So, and I did not come into emergency medicine residency from an EMS background. I actually came from a research lab background. And so it's just a skill you learn over time. And you are not put in the situation to be like the room runner or the decision maker till you have years and years of experience, like being in those high stakes, high stress, critical situations and not being the decision maker, but being part of the team. And then, you sort of progress to the point where you're not the final decision maker, but you're the first decision maker, but you have backup. And so I think you learn those skills when you're in the situation where there's always backup. And then by the time you become the backup and you become the final decision maker, you spent, years and years and years in that situation, learning how to kind of be calm. The other thing I guess I would say is that sometimes the ER can still be really stressful. Like I was working this weekend and I had cases that were really, really stressful and the ED was really busy and very overwhelming at times. And at some point, it's almost like I don't do it as much anymore because I don't have time, but I used to like do yoga and meditate, and you sort of learn to check your own emotional balance at that point. And so I still do that in the ER. Like if I feel like I'm getting overwhelmed or I feel like I am starting to react externally to or internally to the external stress of the ER, I sort of like take a breath and I tell myself like, I'm just going to, complete task A and B and C and D, and I'm going to work as fast as I can and as efficiently as I can. And that's the best I can do. And that's the best I'm going to do. And that's going to have to be good enough because that's what I'm capable of. And I think just like, if there's 20 people in the waiting room and 6 people are rolling in on ambulances, and if you sort of let all of that like drown you and overwhelm you, then it's going to be too much. But if you say, I'm going to just see the first patient and they're and they're the first patient I'm going to see, and I'm going to go as fast as I can, but still be safe. And you just take it one step at a time. And it's sort of like the analogy, like the way to eat an elephant is one bite at a time. Sometimes the way to manage the emergency room is one patient, one step, one decision at a time. And you just have to not think of all the things coming down the line. You have to just, like take the first step, if that makes sense. And for me, when I'm feeling overwhelmed, like I just think to myself, like, first I just sort of check myself emotionally and I say, okay, like acknowledge that you're starting to get stressed and like release that. And the way I release that is to just be like, I'm going to do the best I can. And I'm just going to start with point A and we'll see where we get. So.
Absolutely. Excellent. Dr.
Yeah. And yeah, what I would say is this, I mean, I'm pushing 70. I'm way on the far end of my career. But when I was very young, mid 20s, say, 40 some odd years ago, I was pretty excitable in those days and frankly frightened at times. And I think part of the fear is the fact that you may do something wrong and hurt somebody, number one. And number two, yourself get in trouble. And number three, be thought of as being an idiot, which you really don't want to be thought of that way. The thing that I want all of you tonight who are on with us to be assured of is that what happens with the passing of time as you see a lot of patients is that you begin to develop a maturity about interaction with people, including the team, and by that I mean nurses, respiratory therapists, and so forth, who are very smart people and who will help guide you. So draw on, ask them, what do you think? And then the other thing is, it's deciding if a patient is having an emergency. And if it is it a life-threatening emergency, of which there's only a handful, that you have to act right now, like an obstructed airway, like a patient who has stopped breathing. Brandon, was it our first shift that we walked in that room together? You and me, what, about 7 or 8 years ago?
Yeah.
And we walked in the room and the guy stopped breathing in front of us. I mean, thank God we walked in when we did. Is there a spurting arterial bleeding? Has a patient lost a pulse? In those settings, you have to act now. Indeed, there's an acronym called XABC. If none of those four things are present, you've got a minute. You've got a minute to collect your thoughts and see what you see. For example, the alertness of the patient, the sounds of the airway, the rate of the respiration, and what we call air hunger, the quality of the pulses at the neck and at the wrist, the feeling of the skin. Is it cold? Is it wet? And so forth. Are they having severe pain? And if so, where? And so in which there seems to be an emergency present, but you've got a minute to collect your thoughts and get some tools around you to help you with your patients. So I would just say that with the passing of time of seeing a lot of patients, Elaine and Brandon, and really being able to sift through, okay, do I have an emergency present? And if so, is it XABC, external bleeding, an airway problem, a respiratory, they stop breathing, or they become pulseless, then I have to act right now. Otherwise, you've got a minute to collect your thoughts.
Yeah.
Brandon.
And for those of you students who are a bit more type A's and are writing everything down, thinking these are going to be test questions, I'll let you know when the test questions are going to start. Just sit back and absorb this info here. You don't have to be taking notes right now. So let's move on to the next question. So again, these are things we hear every session. So how do you handle a large volume of training and education? So similar to before, it'd be easy just to say, well, we just do, because what choice do we have, right? It's selection bias in a way. Only those who truly end up handling it are the ones who make it this far and then turn around and teach others about, the path that they went. But in reality, it's not that simple. So sometimes it's easy. We just really, really like the subject that we're studying or learning about, and we just can't get enough. And then that makes learning fun, and mental recall is much more efficient. Sometimes, though, we have to be forced to learn something because we don't enjoy the topic, and you have to learn it to improve your competence or efficiency, and that just makes it much harder. Maybe mental recall isn't as easy, and this type of learning takes a lot of effort and force. By the way, it's my goal one day to do an entire lecture with nothing but GIFs, but not tonight. So they say that the volume of information that you have to learn in medical school, it's like trying to drink out of a hose and not spill a drop. I'd say that's pretty fair. For one, you have to understand that that is impossible. And if you constantly compare yourself to that top 0.0001% who can do that, you're setting yourself up for failure. You think that, I mean, I don't want to speak for all the docs on this talk right now, definitely myself, but don't think that for 1 second that we know everything about everything. Absolutely not. Do we know a lot about a lot? Sure. Is that good enough for the next patient that's going to come rolling in? I hope so. But what if it's not? So, my personal belief is I think that the most important thing that I learned in medical school was not medicine itself, but how to learn. So undoubtedly, I'll see things, if not on every shift in the ER, at least a few times a month that I don't remember. It can be a diagnosis or a drug dosing or something like that. The most important thing is that I learn how to quickly access my resources and get that information. And then when I get home, I learn how to teach myself about that thing that I saw today that I didn't remember off the top of my head, despite how tired I may be when I get home, because that's what our patients deserve.
So Brandon, you're saying that if you see something that you don't know and you realize you need to know it, you don't just kick yourself in the butt. You take an active hand at changing that.
Yeah. What good is it for me to sit there and mope about, oh, I didn't know this, I didn't know that. I've got to be an adult learner and go and correct those cognitive deficiencies because my patients need that. So my personal theory is that there's two types of people in medical school, or really it can be all professional programs for that matter. The more common type, I think, is you're just smart. You can read or hear information and you just do a really good job of filing it away and organizing it in your head. And you can easily recall it when needed. Maybe not quite a photographic memory, but something really similar or close to it. And the other type of person, less common, I think, is the ones who might not be quite as book smart, but they more than make up for it with their work ethic and they just work hard. I'll give you an example. So my brother, he's 1 year younger than me, and he went through medical school when I was going through physical therapy school. And then I decided several years later to go back and do medical school. But he was a straight A student his entire life. He'd never really had to crack open a book or study hard. In fact, during a lot of medical school, he played lead guitar in a rock band that played at clubs. He made albums. He participated in extracurricular substances and activities, and he finished first in his class, 99th percentile on all the standardized tests. And it really just pissed me off. I love my brother, but it pissed me off. I had to work hard for every B- that I earned in my life. And we both came from, the same parents, I hope. And that's just the way that some people are. And so you have to know what type of learner you are, and that you can't try to be the photographic memory person if you're not. So, all right, Dr. Reno, what do you think? How do you handle large, ridiculous volumes of information?
Yeah, I think for me, the first and most important thing to remember is humility. So I remember being told once that medical knowledge doubles every 7 years. And so if I don't know the answer to something, I feel like it's my job to figure it out. But also, it's okay to not know the answer to something. And it's okay to admit that and to call a consultant and to look things up. Like, for me, one of the most dangerous people in medicine is the person who's overconfident, who feels like, hey, I don't need to look this up. Like, hey, I'm embarrassed to admit that I don't know this. And so I think having humility around your own knowledge basis and around your own limitations and working to fill those knowledge gaps, but also being truthful in that, like, you don't know everything and that's okay. especially as an ER doc, is really important. And for me, I'm just okay with not knowing everything, and, working to fill those knowledge gaps, but also, like, I feel like every 2 days a patient comes in and they're on like a new chemotherapeutic that's in like phase 2 clinical trials. And, I may have never even heard of the drug. And so I go and look it up, and I'm truthful about like not knowing things and being humble and finding information and asking for help when I don't know something. And I think that's really important for the practice of an ER doc, because you're never going to know as much about something as some of the specialists. And that's okay, because I didn't do a specialty in, oncology, or medicine is so specialized now and in such tight silos that some of the knowledge depth related to specific things is so deep. And I will never know as much about bone marrow transplants as a physician who specializes in it. But I know how to reach out to them and ask intelligent questions, and I know how to access information. So, and I'm not ashamed to call them and say, hey, this is new for me. Like, help me out here, or here's my question. Like, I'm unable to find the information online, and I just want to make sure that I'm doing the safe and appropriate thing for this patient. So I think that to me is really important.
Yeah, you make a good point. I heard somebody say once that emergency medicine is the specialty that's the second best at every other specialty, which is kind of true, but also a little offensive. I think we're the best at resuscitation and, like circling the drain, critical care, life and death stuff. But yeah, I'm not the smartest cardiologist, orthopedic surgeon, ophthalmologist, kidney specialist, and that's okay. Dr. Fowler?
Yeah, the great thing is that knowledge builds on knowledge. And so as you both see patients, determine what's an emergency, what is not, sometimes the emergencies are quite subtle. A person can be infected and quite sick and not really have a high fever, not really being in shock, and so forth. But knowledge builds on knowledge in sort of two flavors. One, the patients that you see as you study their cases brings you knowledge and cements what you are learning, whether it's pharmacology, whether it's infectious disease, dermatology, and so forth. In our field, where we see emergencies of every organ system, every age, every gender, in every language, at every hour. The other thing is what Brandon really talked about, and Elaine gave some nods to, which is that it's going to be inevitable. There's going to be stuff you don't know. It happens all the time. It happens every day. And so you may have time to look it up during the time you're seeing your patient, but you may not. Somebody just asked the question, in an 8-hour shift in the ER, how many patients do we typically see? And we'll see 20 to 30, on a bad day, 35. Which means that you've got somewhere in the range of 10 to 15 minutes with each patient all day long. And so it can be hard, Brandon, during the shift to be able to actually look stuff up or be able to read about it, except in as much as such things as reference documents for dosages of medications and the appropriate medication for certain diseases, like what antibiotic is best for this infection. What do you think?
I don't know, Dr. Fowler. It's a lot easier with my smartphone. Your flip phone probably doesn't give you as quick access.
You mean this right here?
Yeah.
I didn't know they still made those.
Oh, hush.
All right, I love it. Okay, question number 3. Often you guys ask, how do you manage patients with different beliefs than yours? So to be honest, this is probably the easiest one for me. On my first day of medical school, the first lecture from the first physician, the first words out of his mouth were, "Good morning. It's no longer about you." You should have seen the shocked look on the students' faces. For their entire lives, they've always been, the best of the best and the smartest of the smartest, the top of the top, the most talented, yada, yada. And they're finally, here they are starting medical school. And how dare the dean of the medical school step in there and just bring their pretty little heads down from the clouds back to reality. Folks, we're in a profession that serves others and blessed with the privilege to care for them in their greatest time of need. And so my personal opinion is it doesn't matter what my patient's religion is, what their sexual preference is, how many abortions they've had, who they voted for in the last election, if they think COVID is fake or vaccines are the devil or tattoos or piercings. I don't care. We are both humans who love, laugh, and cry. And right now, my job is to take care of their needs. So no questions asked. That's a simple one for me. Dr. Reno?
Yeah, I mean, I say the same thing. Like it just doesn't bother me in any capacity. Like if people think different things than me, if they have different religious beliefs, if they have different like personal life philosophies, anything like that. I, I don't. It just feels like such a non-issue, I guess. And maybe that's just how we're trained to think, or maybe people who think that way sort of self-select into emergency medicine because we, deal with kind of a wide swatch of the population who all believes and thinks and acts different than each other, right? We're all individuals. But I don't think I've ever struggled with this. Like it just is what it is, I guess. You mentioned like COVID-19 vaccine denialism or COVID-19 denialism, like that for me, I feel like I almost feel bad for people who are in that boat, because to me, it feels like they're risking their health without recognizing. And I have a lot of very in-depth training on like how to read information, critically digest it, and sort of assess it for its reliability, and its accuracy. And not everyone is trained that way. And I don't even know how well all physicians are trained that way. I think a lot of my training in that came from a research background. And so to me, when people approach something like that, the struggle for me is not that I struggle that they believe something different. The struggle for me is that like I'm empathetic to the fact that what I think is that they've gotten bad information and they're struggling to recognize that that's bad information. And so I sort of compassionately direct them to sources that I feel are more appropriate. So maybe that's just like the response to the perpetual volume of false information on Facebook. So.
And Fowler?
Yeah, Brandon, and Elaine, I think it's so very important that we know what we know and be honest about what we don't know and be humble about our own personal beliefs. My own personal belief is what seems to be true, that 96% of everything that's in the universe, we have no idea what it is. A slightly under 5% of all the matter in the universe is what you see around you. 20 some odd percent is dark matter, and the remainder is dark energy. We have no idea what 95% of the universe is composed of. We simply don't know. And I find that a very humbling phenomenon. And so, and from that, I, on my own level, because you asked me the question, that I think that being humble, not being judgmental, we don't have a right to be judgmental. We cannot approve. I had a patient recently who is drinking herself to death time and time again in the emergency department. And what we have to do is hold out our hand and say, we're here to help you, here to get you resources. These are the things you have to do, or you're going to surely die of your disease. However, these are decisions you make. And then the other things about faith is that we must never get in the way of between people and their own spirit. And that is their connection, it's not ours. And so it's exceptionally important that, that we truly honor and remain respectful of what people's belief structures are. There's some people who are quite destructive. We've had somewhere around 300 mass shootings in America this year. Can you believe that? Are those belief structures of someone who would do a mass shooting that we approve of? Of course not. It's wrong, it's immoral, it's illegal. But nonetheless, we're respectful of people and their humanity. So it's tough. It's standing in between a person's humanity and often their behavior. Long-winded answer, Brandon.
Yeah, no, that I agree. And I'll never forget the first words of that lecture. It's, "Good morning. I thought something, medical was about to come out of his mouth. And instead it's no longer about you. And, if I ever become a dean of a medical school, first of all, kill me now if that happens. But if that does happen, that's going to be the first lecture that I give. I'm just going to ask him for his slides because that one was very powerful. Okay, last question, and then we'll go on to some trauma cases. So you guys often ask, how do you deal with delivering bad news? Like before, this is an art. It takes a lot of repetition to get it right, which unfortunately means a lot of bad outcomes. And so that magic number is different for everyone. Some people are better at conveying compassion and empathy than others, and some are better at communication than others. So just because you were accepted to a medical school or another professional program, it doesn't mean that you possess these skills naturally. And there's a reason that admissions committees look for these characteristics, and medical schools help to foster these traits. Also, depending on the specialty that you choose, bad news is just kind of a part of the job. And unfortunately, it's one of the most unpleasant parts for that matter. So how do we deal with it? Well, I've certainly had my unfair share of experiences with delivering bad news. I've been taught by some great faculty how to do it properly. I've also seen some not so great examples. You learn how to read the room when it comes to sitting down with friends and family members and breaking the news to them. But we're not talking about the technical aspects here. We're talking more about, what do I do with that experience after I walk out of that room? For me, I'd be lying if I said that it doesn't affect me still to this day. It just depends on the case. Obviously, if it's a 85-year-old great grandmother with advanced cancer, I don't feel too bad about that. If it's a child, it messes with me, especially as a parent. So, all I know now at this point is you can't be passive or ignore your feelings after a few cases. You can't bottle it up or internalize everything. It will eat you up. It'll shorten your career and possibly even have negative effects on your health. But it's also not fair for me to bring that emotion home and unload it on my non-medically trained wife or my kids. So what's the solution? Well, I'll be completely transparent and honest with you all. I haven't figured it out yet. So personally, I tend to bottle it up a little bit. I know that's not best for me. I'm not like, going to the bottle or, doing anything illicit to dull the pain. But, for me, I haven't quite figured this part out yet. And I've been doing it 19 years total, but only 4 years out of training as a physician. And so I'm going to defer to Dr. Fowler, who's got a couple more gray hairs on his head than I do. And let me know, what do you think?
Elaine, you want to go first or me?
I can talk, and then I love kind of your impression. So this is a really interesting question for me, and mainly because I feel like I've been through a lot of it personally. So when I was a medical student, my mother was diagnosed with cervical leiomyosarcoma. She was the 30th case in the United States at that time. Maybe there's been like 2 more by now, but and then we thought she went through like very aggressive cancer treatment, and we thought it was gone. And then I very distinctly remember, and I think I'll remember it like every single second of this interaction for the rest of my life, when the cancer returned. And here's what I remember about it. And it became very true when they taught us about breaking bad news. So I was sitting in the lobby of the Cleveland Clinic with my mother and my father at her oncologist's office. And there was this long hallway, and her oncologist stepped out of a patient's room, and we were waiting for the appointment. He stepped out of the patient's room, and he looked down the hallway, and he made eye contact with me, and it was like his entire face just like sank, and his entire like demeanor just like collapsed a little bit. And I knew in that moment that the results of her PET scan were going to be bad, because I could just see it. I could see it on his face. I could see it in he looked at us, and it was like he said to himself, like, I'm going to have to tell them that it's back and that there's nothing we can do about it and that she's going to die. And sure enough, like 30 minutes later, that's the exact conversation we had. And she did go on to die of the cancer, and it was not treatable at that point. And so in medical school, we learned about, like, when you're breaking bad news, like that you fire a warning shot and then you tell the family, and then whatever you say after that, like no one will ever remember the words you say. They will remember kind of the emotion and the empathy you convey. And that was my lived experience. And so for me, like when I'm breaking bad news, like I try and remember to convey not just the words, but like the empathy, and to be supportive for the family. And I mean, how you deal with that, like, I think it's the same thing. Like, it's just really hard. I found, like, to me, like, work sometimes feels so emotionally real that, like, when I'm not at work, like, I don't read books anymore that, like if I read, it's like beach reads. There's like, when I watch TV, like, it's like, not, I don't watch documentaries. It's like reality TV. For me, it's like, the emotional load of work is enough that, like, in my personal life, like, I don't need to listen to podcasts that are sad or about true crime or anything like that. Everything else I do outside of that is almost like fluff. And I think it's like a sort of letting my brain decompress. And then I exercise, which I find really helpful to sort of like emotionally offload. I talk to my really good friends from medical school. All of those things I think are helpful, but I don't know that there's a perfect solution to this. I think if you hit a point where you can walk in and tell a family that their loved one is going to die of cancer, or that their child has been lost, and like that doesn't get under your skin in some capacity, like, I wonder if it's time to retire. So maybe that's not true. Maybe other people are like able to do that and just walk away, but that is not who I am as a person. And I don't think I will ever get there.
Brandon, firstly, it's really hard early on when you have to be involved with giving bad news to patients. Typically, the students and even the residents may not be the first ones to deliver bad news. And so when you're pretty young, early in school, you're not the primary one, but over time you observe bad news being given. Now, for the students listening, think about this for a moment. Patients come to see us by and large for two reasons. Number one is to keep them from dying. The second is to help them deal with a medical condition that's not going to immediately or soon take their lives away. Most people, and I could probably, Brandon and Elaine, we could count on two hands, maybe three, between the three of us, on the last couple of shifts, how many people came in that were about to die or were dying? Not many. There were some, but not many. And so then there is the occasional time where the situation is set up and you've gone in and you've taken a guy who's had a heart attack and you've done a cardiac arrest. You have the tearful family in the waiting room, and you have to go out, especially when you're a younger person, and say, I need to talk to the wife. And you have to decide if you want to do it right there in front of a crowd, or ask them what they would prefer, because they have the family has to have, or the patient, some sense of control. Remember, when they lose control, they lose hope. And when they lose hope, they lose everything. And so you get better at it over time. I would say two last things. It is my style to give people bad news in bites so that they don't, you got cancer and you're going to die. I don't say that. It would be, well, I got the results of the chest x-ray back. Yes, doctor, what did it show? Well, there is a thing over in the right lung field that wasn't there the last time we took the x-ray. And there's a group of things it could be, some of them not so serious, but what I am concerned about is that this could be a serious problem. After all, this is your chest x-ray. And as you know, you had colon cancer and you were a survivor of that. But I think one thing that we have to worry about is that this is possible, that your cancer has come back. Now, this is in the setting of the fact that I know full well that's exactly what the problem is. but I'm not laying it on the patient all at once. Give it to them in bites. Let them digest it a little bit at a time. That's important. I guess the last thing I would say, and this is a little off the wall, but I hope you'll all forgive, is that it is exceptionally hard for a physician to be involved in the care of for a doctor to be involved in the care of their own family. It's a very personal, very emotional thing, in part because you know too much. My dad, who had a heart attack and then he had a cardiac arrest at the age of 83, he was a great old Army general, and that was horrible. And then my mother, at the age of 93, was really still alert and pretty lucid gal, living independently, ruptured a duodenal ulcer, peritonitis, shock, went to the OR, tried to save her life. And there, with the pulmonary breathing assist device on, she said, "Let me go." And you go, whew. And so my brother and I, had to sign the DNR form for our own mother. God almighty. It's very hard for a physician to be involved in medical care of their own family.
Yeah, that's this was not planned. And this question, we didn't talk about our answers before, but the irony, I also went through a similar story with my mom with cholangiocarcinoma when I was a third-year resident, and being involved in her care and a lot of the doctor's appointments, the initial surgery, all the chemo, radiation, the multiple rounds of being intubated in the ICU until the last time she got extubated and said, "Don't ever do that to me again." And then that's when we had to have the tough conversation about goals. But maybe, I don't know, maybe that's the trick, you guys. Maybe being a part of those experiences growing up adds more human to you when you're the one delivering the news, because you turn that empathy into sympathy almost. You have a lot more compassion because you've lived those experiences. Yeah, that was not planned, that all three of us we're going to have some more stories like that. So, all right. So that's the end of, it was just 4 questions there. And that actually took up 46 minutes. So before I go on to the first case, I see there's a lot of questions that are accumulated. Kiana, you want to do like 4 or 5 questions before we roll into the first case?
Yeah, sure.
Okay.
So I have a lot regarding our past conversation that we just had, so I'm just going to quickly go over those.
Okay. I didn't mean to, I went off script a little bit here.
No, you're good. So the first one I'll ask is, how do you manage a patient who has given up hope on their own recovery before you do, or the other way around? And I'll also tie it into this other question is, do healthcare professionals form mental health support groups to process these tragedies?
As far as patients who give up hope, that's kind of a tough question to peel apart. It depends, if they've reached the end of treatment options and give up hope, then that's where you, try to comfort them and understanding that, the disease itself, may have, I don't want to say won or taken over, but there's medicine doesn't know the answers to everything. And, the few times I've seen this, we don't get a lot of this in the ER, but the few times that I have seen this, I don't think that patients' acceptance of this is the issue. It's usually the family members that's the issue. The patients themselves are usually at peace with the decision. Now, if they're giving up hope when there's still plenty of options out there, then that's just a discussion where we describe, we educate them on what the options are, the risks and benefits, and we let them make that decision. As long as it's an educated decision and they truly understand all the pros and cons or risks and benefits, all we are the ones who give them the information. We can't make that decision for them. So it's we're their coach, their cheerleader, encourager, so to speak. I'll let y'all answer if you had anything else to add to that one.
Brandon, that was excellent. I don't have anything to add.
Okay. What was the second part of that question? I don't even remember.
If there's any sort of groups to help with tragedies among healthcare professionals.
Oh yeah, there's the 5 o'clock happy hour group. No, I'm just kidding. um, yeah, you know, off the top of my head, I don't think we form groups necessarily, but you do learn the physicians and colleagues in your group that are ones you can lean on, the ones that you identify as mentors early on. No one should start a career in healthcare without having mentors available, someone that does what you do in the area that you do it in, and understands. You need somebody that can tell you it's okay, you did everything right, or tell you when you're acting like a knucklehead, if need be. So, but as far as like groups, not necessarily.
I can say, so after difficult cases, one thing that we do really commonly in the ER is like a debrief. So, and debriefs have been shown in the literature to help people cope, but like we'll get together and even if just for a minute, talk about what went well in the case, talk about what we could do better. The other big example of this I have is, so I'm a physician in Denver, Colorado, and I assume you guys have experienced this because your doctor's in Parkland. But I was a resident when the Aurora shooting happened, so the movie theater shooting. And that was just an awful experience, I think, for everyone. Like that lived experience was not good. And so there was like a lot of emotional support and emotional outreach that happened to us afterwards, including, interestingly enough, like emergency rooms all over the country who had been through something different, like started sending us food. Like we would be at work and like a pizza would show up like from some ER, like halfway around the country. Like, and they'd be just like thinking of you guys. Not at the time, obviously, but later. And then for years afterwards, up until COVID started, on the anniversary of that event, the staff that was on that night would get together and remember the victims and remember that. And then at one point they even started a 5K that only the staff would run usually, and it would like each mile would have like, or each set point would have like, not the name because it's HIPAA protected. Well, actually they've been publicly released, but like a memory of one of the people that died that night. And they used to charge for the race and like a nominal fee and then like donate it to some charity as like just a way for people to cope and to kind of like process what was, you know, because like being a physician or a healthcare worker and then having a mass shooting and like seeing that, like that's just really not a normal experience to live as a human. And I think the support that came up around that was probably what pulled a lot of people through it. So.
All right, Kiana, one more question and then we'll go into the case.
Sure. Dr. Riener, you were talking about how you have like a great support system. And so there was a question going into, I'm asking, can you go, oh wait, excuse me. Is how often do physicians tend to ask each other for advice, including in ER such emergency medicine, where judgments have to be made extremely fast? So anyone of you guys can answer that question.
As far as Parkland, we have anywhere between, I think, 7 and 10 attending physicians working at one time in the ED. And so if, you know, the emergencies, the ones that are coming in trying to die, those are not the ones that we need the help with. To be honest, the sicker they are, actually, ironically, the easier it is to take care of them. And so for those, I think most of us that have gotten at this point in our training, we're not asking for help there. It's usually more of the like clinically complicated cases or a weird EKG or maybe a diagnostic dilemma. And those all the time, I'm walking to the pod next to me and I call it the attending, and I go ask Dr. Fowler, how many times have I brought you an EKG and we pull out the calipers and do some investigating? You know, I
gave you a damn pair of calipers. You better still have them.
I do. I think it's a sign of.
All right, no, all the time. Yeah, I was playing. You know, it's the collegiality is so important. I love being where I am. There are 6 other faculty at any given time. Can you hear me okay, Brandon? I just got an unstable thing. Can you hear me okay?
You're good now.
Hello? Okay. My internet is geek. But we will have as much as 150 years of clinical practice in the experience of the faculty on. I mean, hell, I've been doing it 44 and Swinton's been doing it 35. And so we're in there. We've got 80 some odd years of experience between us. So it's so important to be humble about what you know, what you don't know, and go ask people. Anyway.
All right, guys, let me bust through my case so we can finish up. After my case here, we have the official Q&A break here. We can do a couple more questions. So first case, this is where the quiz questions start, FYI. So for those of you taking notes, the second hour is the source of your quiz. So this case is going to end with a resuscitative hysterotomy. And if you've never heard that word before, then buckle your seatbelts. Speaking of seatbelts, this is a case. So this one was, this is not the actual picture, but I modified this from a case that I had early on as a paramedic, not as a physician. So middle of the afternoon, single vehicle accident, 911 called. On arrival, we get there, we have a single female passenger in the front seat, estimated to be in her late 20s, unresponsive. It looked like she was pregnant just based on the size of her abdomen, and immediately check a pulse. She has a thready and rapid pulse, and she's breathing shallow. While firefighters are trying to extricate her, we put a cervical collar around her neck to protect the neck. We begin assisting her ventilations with the bag valve mask with oxygen flowing through it. And we're able to get her out within about 10 minutes to cut her out, put her on a backboard, and get her into the ambulance. So once we got her in the ambulance, we repeat the primary assessment and begin hooking her up to the monitor. So in trauma, you begin with the primary assessment. It's A, B, C, D, E in that order most of the time. First, we find that the airway is patent, meaning open, and she does have some blood and saliva in the back of her throat. So we suction that out. And the second step is B, breathing. So for her, we know her breathing is too shallow. It's only about 6 breaths per minute. So we are breathing for her with the bag valve mask at a rate of about 10 to 12 breaths per minute, again, with supplemental oxygen going through it. And part of breathing is listening to the lungs. And so she has equal breath sounds on both sides, which is normal and expected. C is for circulation, and we determined that she has no obvious hemorrhaging anywhere, and she does have that weak, thready, fast pulse. Meaning that she's probably not circulating a large volume. She may be internally bleeding for all we know, but we don't know for sure. We find a pulse on the carotid artery on the neck and on the femoral artery in the groin, but not on the wrist or in the feet. So that usually indicates that the blood pressure is pretty low. And in fact, when we measure it, it's about 60/40. So we put 2 large IVs in her. We start some fluids, knowing that she's critically ill. We are going to keep monitoring her ABCs while we move on to the next steps. So D is for disability, and there's a couple ways to do this. So the easiest way is called the AVPU scale, the AVPU scale, and you just determine how alert the patient is based on this chart here. The second way is the Glasgow Coma Scale, and it's a bit more complex. It's mainly for patients with head trauma. And for us, our patient doesn't respond to, she doesn't open her eyes to a loud voice or painful stimulus like squeezing the trap muscle on the neck or a brisk sternal rub. She doesn't open her eyes to that. She doesn't make a grunt or a moan. When you try to elicit a motor response, there isn't one. So she gets a GCS score of 3. The final letter is E for exposure, meaning that we try to cut or strip away as much of the clothing as we can so we can identify any potential hidden injuries and prepare for the secondary assessment. So now that the primary assessment is complete and all the immediate life threats have been identified and addressed, we start our rapid transport to the nearest trauma center. Now, before we move on to the secondary assessment, it's important to realize that you always have to be keeping a close eye on the components of the primary assessment. And at any time, you may have to come back to your primary assessment to intervene. So now it's like you're doing 2 things at once, your primary assessment, and we're going to move on to the secondary. So in the secondary assessment, we do this while we're driving, lights and siren to the hospital with her. We're trying to just find any other injuries that she may have. So depending on the situation, some patients will have multiple injuries, and the more significant ones are going to take up most of your time and attention at the expense of ignoring the more minor ones. So sometimes you're so busy managing the primary assessment that you never even make it to the secondary assessment in the pre-hospital setting. Assuming you can do the secondary assessment, the goal is to be methodical and go head to toe rapidly to find any injuries and, do things like bandaging or bleeding control, splinting, stuff like that. And there's a lot of mnemonics to help remember what to look for. Specifically for me, I learned DCAP, BTLS. This is not going to be on your test. Don't memorize this for the love of God. But it stands for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. I used to say that stuff in my sleep, 20 years ago when I first memorized it. So for her, we find a lot of abrasions and marks on her chest and her abdomen that look very similar to the width of a seatbelt and likely from the force of the accident. She has scattered abrasions and superficial cuts all over her arms and legs. But most importantly, you find the gravid appearing abdomen, and the fundal height is about 4 finger widths above the umbilicus. So what does that mean? Well, a real kind of quick and dirty way to estimate the age of the fetus is to first find whether or not the top of the uterus is above or below the umbilicus, or the belly button, if you didn't know what that meant. Because that indicates the 20-week mark if it's at the belly button. Then for every 2 finger widths above the belly button, you add about 4 weeks. So she was 4 finger widths above the belly button. So that'd make her around 28 weeks roughly. And for reference, a fetus is considered viable beyond 23 weeks. And full term is 36, but you're usually not born until 40 weeks. So we estimated her to be about 20 weeks, which means that the baby is potentially viable, but definitely not ripe yet. Can I say ripe? I don't know if I can say ripe. So remember what I said earlier about always repeating the primary assessment as we go? Well, with our patient, we're about 3 minutes out from the hospital or so, and we lose her pulse. So y'all throw it in the chat. What do you start doing when you lose a pulse? Good. Excellent. Alana wins. She got it first. CPR. So performing CPR on a pregnant female is different. First, as the uterus grows, the organs are being pushed upwards. So instead of hands in the center of the chest for chest compressions, you'll slide up about 1 to 2 inches to compensate for the heart will be. Second, the most important is to think about the anatomy in the abdomen. So what do you know about the relationship between the fetus inside the uterus and the great vessels, as we call them, or the aorta and the inferior vena cava? And I'm going to show a video. So let's hope that the bandwidth works on this one. And first of all, I apologize. It's Dr. Oz's voice, which I think he's a quack and a half, but he had a really good video here. So ignore the fact that it's Dr. Oz.
It's a good idea to avoid lying on your back as your pregnancy progresses. Lying on your back after about the 4th month of pregnancy puts the full weight of your uterus on the inferior vena cava, or IVC, which normally brings blood back to the heart from your lower body. This reduces the flow of blood to the heart, which decreases the blood flow to the uterus and baby. This position also puts pressure on your spine, back muscles, and intestines. Lying on your side takes the pressure off the IVC.
Thank you, Dr. Oz. All right. So it is yes, the great vessels are squished by the baby, especially the bigger that the baby gets. And in particular, it's the vein, the inferior vena cava, that's more important because that's the tube that takes blood back to the heart. And if you don't get blood back to the heart doesn't have anything to pump out to the rest of the body, including the baby and the mom's vital organs. So this shows you a couple photos, and the one on the right, it's like you're standing at the feet looking up into the abdomen. So you can see the relationship there. The inferior vena cava is more on the right side and the aorta is more on the left side of the spine there. And so definitely gets squished because the walls are a lot thinner. So when we do CPR on a pregnant patient, especially that's far along, third trimester, normally when we do CPR, we put them on their back. So in this case, do you think that's a good idea? No, good job. And that's why we're taught to perform what's called a left uterine displacement or a manual uterine displacement to try and manually pull or push the uterus off of the IVC, which hopefully improves venous return to the heart and improves cardiac output. So on the left, this shows two options to either have one person manually push the uterus to the left while the other does chest compressions, or you can place a wedge under the right side of the patient and tilt them to the left, which is the older practice. You might still see some people do that. On the right, this shows how it would look in real life, although this is obviously a mannequin. So for our patient, we're doing CPR on her with a left uterine displacement technique, doing compressions at a rate of about 100 to 120 a minute and doing our rhythm and pulse checks every 2 minutes. We put an advanced airway in her and breathe for her with a bag valve mask. We're giving her the epinephrine, and she continues to be in a rhythm that is not shockable. And so we call the hospital on the radio and give them a radio report and let them know that we're about 3 minutes away from the trauma center here. So in the ED, knowing what I know now about on the receiving end here, in the 3 minutes prior to us getting there, they are busy. They're going to page out the trauma activation, notify the OB/GYNs, physicians, notify neonatology and pediatrics. They're going to get the resuscitation room ready, get dressed up in their PPE. And then when we get there, it all happens pretty quick. We give our verbal report as we're continuing the care of the patient and transitioning the patient into the hospital bed. The CPR is continued by the ER staff. They don't get any return of spontaneous circulation within 4 minutes. And within that first few minutes, the OB/GYN and neonatology teams arrive, and the decision is made to perform a resuscitative hysterotomy. So what in the world is that? Well, it used to be called a perimortem C-section, which is morbid, and we don't call that anymore. We call it a resuscitative hysterotomy because, ironically, cutting a giant hole in the mother's abdomen and taking the baby out while the mom is in cardiac arrest actually can help to resuscitate the mother and lead to a higher chance of survival. So it's a rapid surgical extrication of the fetus via a kind of a real quick and dirty C-section in hopes of increasing survival for both the mom and the fetus. The goal is to begin the procedure within 4 minutes of arrival in cardiac arrest and have the baby delivered within 60 seconds. That's fast. There's some case studies that have shown survival when performed up to the 15-minute mark, but obviously for every minute that you go, it's a decreased chance of survival. So while it may seem brutal to basically cut and rip the baby out in less than 60 seconds, it does lead to significant physiologic improvements for the mom and increases her chance of survival. So like I said, the uterus compresses the IVC. So taking that baby out allows more blood to return to the heart And that uterus also displaces the diaphragm upward. So taking the fetus out allows the lungs to expand better during artificial respirations and improves pulmonary mechanics. And the uterus also receives about a third of the maternal cardiac output. So removing the fetus and the placenta out with it allows that blood to circulate to the mother's vital organs instead of the fetus. In the end, it's all about the mother's heart, lungs, and brain. So let's be clear. The decision to do this is anxiety provoking and nerve wracking and will strike fear in the hearts of even the most seasoned emergency medicine physicians or trauma surgeons or OBGYNs. But the decision has to be made early and quickly, and the procedure has to be executed without delay because the survival decreases for every minute that you go without doing it. So the steps of how to do it. So first of all, this picture here is all the instruments that you need. You need a couple hemostats or clamps, some bandage scissors, and a scalpel. So if time permits, you can place a Foley catheter to decompress the bladder. It's not mandatory, but it does actually help to gain access to the lower part of the uterus, and you don't want to cut the bladder. That's poor form. So you do chest compressions up until the moment when you're ready to cut, and then you pause chest compressions while you're making the quick scalpel incision. And then that's through the skin and the subcutaneous tissue. And then the second incision is made through the uterus itself, just a little cut, and then you extend with scissors because you don't want to go slicing into the uterus and risk cutting the baby. Then you pull the baby out, you suction the nose, then the mouth, you clamp and cut the cord, hand the baby off to the neonatology team, deliver the placenta, and just pack the uterus with towels to control the bleeding. And then you continue your resuscitation of the mother while continuing to take care of the baby, of course, too. But now you got 2 patients. So this is a video that demonstrates in a simulated environment. It was actually during a conference that they filmed it, the steps of that. So hopefully the bandwidth is good for this.
This is the best model I've ever seen for crash C-section. These are the folks from Operative Experience. They were kind enough to make this happen. We're not going in depth in the scenario. It's a 32-week pregnant woman who, right as she pulled up on the ramp, went into cardiac arrest. And we're here for anything you need. We'll leave it to you. Sarah, take it away.
You can run the arrest at the top, Scott.
All right.
All right. Do whatever you need to do up top there. Well, I have 2 minutes to get my gear set up. This is Brett. Brett's my sim guy. Okay, so I'm palpating abdomen. I clearly have a lady in cardiac arrest, palpably pregnant, right? Fundus well above the umbilicus. So I have my indication to do the procedure, and I'm gonna start right at the top, up at the xiphoid, and then making a pretty big incision just vertically all the way down to the symphysis. I'm not a surgeon, right? Leon's a surgeon, but for me, I gotta cut a few times to get through all these layers. Especially for this lady. Okay, you can bluntly dissect as you need. Okay, and at this stage you can have your assistant retract. I've got uterus here, bladder low down. I'm making a smallish incision in my uterus. You get umbilical fluid splash out there. And I'm just putting my fingers in because I don't want to use scalpel the whole way and risk cutting baby. Using my fingers to protect as I'm opening up the uterus. And for me, I got to make a big incision, right? This is not cosmetic. Reaching in for baby's head. Baby is head down. That's nice. Oh my gosh. And sometimes you need some fundal pressure from the top there to help deliver baby. That's you, Brett. Your fundal pressure. The fundus is up the top. You got it, buddy. He's awesome. Right, next step in baby, you're clamping the cord, 2 clamps, cut between them, right? Don't make the rookie mistake of cutting on either side. You're passing baby off to your neonatologist who's now doing the hard part, right? Tell me you're gonna breastfeed, okay? You're back at baby. You still need to deliver placenta, right? Placenta is the part of this that consumes all the oxygen. And now, if you're a surgeon, you're making the layers nice. I'm not a surgeon, so I'm packing the abdomen with sterile towels. We use this because we have this. You're closing, and if I have a stapler, which I do not, I am stapling the skin shut. Comme ça. Then you're going back to mom and baby.
I think that deserves some applause.
All right. So that, I mean, other than there's usually no laughing. There's complete concentration and some anxiety in the room when this is happening. But this is obviously a conference in a simulated environment, much more stress-inducing in real life. So that just shows you the steps, because a video is worth a million words. So back to our case, the neonatologist and the pediatrics team, they receive the baby and immediately go to work with their resuscitation algorithm. They do warming, drying, stimulating, assess the baby's ABCs, and due to the prematurity and respiratory distress, they have to intubate the baby. But the baby responds well and has a good, strong heartbeat, and definitely going up to the neonatal ICU for probably several weeks. The first 24 hours are always critical for the baby after a procedure like this. For the mother, the emergency medicine team and the trauma docs go back to working on her, performing CPR, transfusing blood, ventilating, pushing medications. At this point, she's about 45 minutes from her car accident and about 15 minutes into her cardiac arrest. The team is getting tired, but they keep working diligently, trying to resuscitate her. She ends up getting bilateral chest tubes placed in case she maybe had been bleeding out into either of her thoracic cages or had a collapsed lung, but that didn't result in any changes. After about 10 more minutes, the team checked for a pulse again, and she had a weak and thready pulse. So immediately her vitals were assessed, and now she has a very weak blood pressure, but at least there is a blood pressure. They make the decision to rapidly take her up to the operating room and do an exploratory surgery to try to identify and correct any other injuries and try to save her life. She was in the OR for about an hour with the surgeons as they were trying to do their damage control, multi-systems trauma, lots of damaged organs, lots of bleeding into her peritoneum and her abdomen. And despite the surgeon's best efforts with working on her for almost another hour, she did go into cardiac arrest again, and they worked on her for quite a while and eventually ceased their efforts and called time of death in the OR. So let's debrief on this case. So what do you guys think went well in this case? You can just throw it in the chat. You know, Dr. Reno talked about in cases like this, it's always important to kind of do an analysis. So yeah, the speed of the procedure, getting the baby out, you know, obviously the time goals were met, and everybody worked well together to get the procedure done and the baby delivered. Right now, the baby's alive and has a pulse at this point. All right. Actions of EMT before arrival. Yep. Thank you. I thought I did work pretty quickly. I was terrified. I had never seen that up until that moment. I didn't even know that a procedure like that was an option or a possibility. So yeah, quick response from EMS. All right. Opportunities for improvement. You guys may not know because you know, it's hard to know unless you were there and know all the intricacies. But opportunities for improvement were actually really challenging to try to come up with in this case because you know, the communication was good. The team was all there in a very timely manner without delays. The procedure was done like we wanted. You know, when we really tried to analyze what could we have done different or better, and we really struggled to come up with anything, which, you know, in a way kind of helped to validate the performance. We did the best we could. You know, we talk about what can we learn from this case. We talked about what the case taught us about preparedness, practice, rapid mobilization of teams, communication, teamwork, and all that stuff. More importantly, the aftermath of the case. You know, this is not an ideal outcome, clearly. And we had to learn how to cope with our emotions in a less than ideal outcome. Now, at this point, I had had a fair number of bad outcomes as a fairly new paramedic, but nothing I had ever seen would have prepared me for what I saw in this moment here. And I actually didn't know she had died until I came back later to deliver another patient, and I found out. So we debriefed. They actually brought me in for that debrief, and I appreciated it very much.
Brandon, how far along can the mother be in her pregnancy? For example, one question was, can you do it at 4 months, 6 months, and so forth? How far along does the mother have to be for the fetus, the infant, to be survivable?
The top of the uterus needs to be above the belly button. It's literally as simple and as quick and dirty as that. It's a guesstimate. So if the top of the uterus is above the belly button, we're going to try. If we happen to know how many weeks, because there's a reliable family member giving us a history that the lady is 25 weeks, then yeah, well, as long as it's over 23 weeks, then there's a good chance of survival. Now, you got to go deliver it someplace that has a good neonatal ICU and neonatology team. So in conclusion, and then we'll do probably just roll right into Dr. Fowler's case. So to wrap this one up, the management of trauma, it's a systematic approach. It's important to have the steps outlined in your head. So as you approach these scenarios, you can do all the necessary things for your patient, but you also got to be ready to adapt at whatever the scenario throws at you. Requires you to integrate everything you know about anatomy, physiology, resuscitation, critical care, pharmacology, fluid physics, acid-base chemistry, all the stuff that you thought you'd never have to know, and do it all in a calm, cool, collected manner while everyone around you may be chaotic and screaming and crying or dying. Like I said earlier, you learn this through practice and repetition. So successful management of the critical trauma patients, it definitely requires a team effort with good communication skills, closed loop feedback. The leader of the resuscitation room has to be able to lead the room, be assertive, but not overbearing, definitive, but but collaborative, and authoritative, but not yelling, and dominating the room. Leadership like this is a fine art, and some are better at it than others. And then finally, we talked about the resuscitative hysterotomy, what it is, how it can help to improve the odds of survival of both the mom and the baby. But unfortunately, we didn't have such a good outcome in our case, including the baby died on day 3. So, that brings us to the final teaching point that not everything we do in medicine is successful, and you have to be prepared to handle, not only the positive emotions, but the negative ones as well, and all the consequences that come with failure. Again, we get better with experience, and I don't mean that we just make fewer mistakes with experience, although that should be true to some degree. I mean that we just get better at managing failure the more times we fail. And the longer you do this, the more times you fail. Everyone has their own kind of personal ways, like we said before, hopefully healthy ways, because the longevity and success of your career depends on that strategy. So that's it for me on this case here. Technically, we have a Q&A session there, and you guys, y'all can hit me up on Twitter if you have any questions or want some advice or mentoring. This session and all the sessions we do can go well beyond a typical Tuesday night together. So Ray, with that, I'll pass the baton over to you, and we can do Q&A at the end.
Yeah, let's do that. We're at almost 8:20 now, and I apologize in advance. My internet's been acting up a bit today, so I hope to heaven that this thing works out all right. And you are going, let me put my video on. Brandon, you might turn yours off, and I will go ahead and share screen. Here we go. Somebody text me if you suddenly can't hear me. Let's see, I didn't mean to do that. Stop share. Let's see, share screen. I'm sorry. Here we are. All right, off we go. Brandon, can you hear me okay?
Yeah, you're good, and your screen's sharing well.
Good. Okay, please, somebody text me or something if the internet screws up. All right, so we'll talk. We'll talk now about a disagreement among friends. So the guy comes into the emergency department with this gaping stab wound in his back, and he is desperately ill, very, very sick, very weak, rapid pulses. And just for a moment, you say to yourself, you know, what happened to this guy? He was stabbed by a buddy of his. And you say, I wonder what they were talking about right before the stab wound occurs. Have you ever thought about that? What brought this on? And I said, it could be that perhaps they're both future astronomers and they were having a conversation debating the elliptical nature of the orbit of Jupiter versus the orbit of Mars and the 10-hour spin speed of Jupiter around its primary axis. It could be that they were having a scientific discussion. I suppose that might be what happened, but it also could be that it was just a drug deal that went bad. Regardless, you have this person presenting, in this case, with chest trauma that happens to be on the posterior aspect of the chest. Generally speaking, we are talking about, when we say chest, from the bottom of the ribs to the base of the neck. There are two general ways to injure the chest. You can injure it bluntly, such as taking a steering wheel into the chest during a car wreck, or you can be injured in a penetrating manner, such as this case, which was a stab wound or a gunshot wound, which actually traverses the chest wall. We will do a number of things to try to evaluate the patient. For example, early on in the patient's stay, after we've begun to initiate the assessment of the physical signs, we will get a chest x-ray to see what we can see about, in this case, the mediastinum, which is the center of the heart, the center of the chest. And here is the heart here. Here is the left lung field here, which you can see blunting of the angle there compared to this angle here. You suspect already, especially with this patient lying down, that there may be blood free in the left chest. And in fact, that we get an x-ray from the side and we see that this was a very energetic person that hit our friend in the back with a knife. And so in this case, we wonder, are there multiple ribs that might be broken, producing in that setting a piece of the chest wall where the lung goes, where the ribs go in and out? We call that a flail, or is this a single puncture? As we initiate resuscitation, as we initiate various procedures like airway support, like breathing support, like what hemorrhage control we can do, we will draw blood. We will do a full exposure of the patient to determine what other injuries may be present. We will take briefly our stethoscope, and you can sort of imagine with this patient, this being the left side, the right side of the patient, and this being the left side, that breath sounds, this is what lung tissue looks like. And the lung tissue is missing here on this CAT scan. So you can imagine that the breath sounds on the affected side would be diminished. And in fact, when we get the patient back with a chest CT, we find, in fact, that there is free air out in the chest where the lung is collapsed. Compare this lung and this dark area that should not be there to this lung that is fully inflated. And this is blood that is free in the chest cavity. This means that hemorrhage has occurred. And here is just another example. The lung should be completely expanded, as you see here, as opposed to this is P for pneumothorax. And you notice in this case, the heart should be smack dab in the center of the chest, but it isn't. And in this case, the heart is pushed to the left side. And this is a tension pneumothorax where the lung is collapsed. There is free blood. This is probably a unit of blood or more that's free in the chest cavity here. This patient is clearly in bad shape. And so the chest is a large exposed portion of the body that's vulnerable to impact injuries and to penetrating injuries. It houses the heart, the lungs, and the great vessels. And so thus chest trauma is frequently life-threatening. Injuries to the ribs, the thoracic cage, and its contents can restrict the heart's ability to pump blood or the lungs' ability to exchange air and oxygenated blood. You remember what Brandon said a while ago about when the heart is a pump and the heart pumps out what it gets back. And so in the case of that baby over 6 months lying on the mother's inferior cava, inferior vena cava, then blood is not being returned well to the heart, and so therefore the heart's output drops. The major danger with chest injuries is internal bleeding and organ puncture. So we start really with saying, is the patient in shock? Is the pulse rapid? Is the skin pale? Is the skin wet? Does the patient have evidence of air hunger where they're breathing rapidly and in a labored kind of fashion? Are the pulses weak? Is the blood pressure as measured low? And if shock is present, do you have decreased breath sounds on one side, or do you have normal breath sounds on both sides? If you had diminished breath sounds on one side, we would percuss the chest, where we actually strike the chest to hear what it sounds like. If the chest percussion was dull, then there is likely free blood inside the chest cavity that should not be there. We call that a massive hemothorax, hemo meaning blood, thorax meaning chest. If there is hyperresonance to percussion, think of thumping a watermelon. This could possibly be a tension pneumothorax in the setting of shock. If the patient is in shock, but the breath sounds seem to be normal, but the patient is in shock, then there could be a cardiac tamponade present, where we would check for distended neck veins, which means blood is having difficulty getting back from the top of the heart, back from the top of the body down to the heart, muffled heart tones, which means there's blood around the heart, a narrowed pulse pressure, and if feasible, a change in systolic blood pressure during inspiration. Indeed, with a penetrating injury like this, we suspect the chest wall is disrupted. There almost certainly is a pneumothorax, which means collapsed lung, with subsequent inadequate gas transfer from loss of mechanical function, resulting in low oxygen levels in the body, which causes ischemia, acidosis, and worsening shock, or a tension pneumothorax, where there is free air that has gotten into the thoracic cavity under pressure, preventing blood from coming back to the heart, causing shock, or a cardiac tamponade, where there is blood around the heart itself within the pericardium, inducing shock because the heart can't fill, resulting in changes in intrathoracic pressure inside the chest, reduced venous return, and low blood pressure. Finally, there are big blood vessels inside the heart. There is the aorta. There are the blood vessels going off to the lung. The heart itself can be lacerated, resulting in profound hypovolemia, which means low blood inside the arteries and veins, secondary to great vessel damage or cardiac damage, and resulting in reduced cardiac output. If the pericardium gets blood can accumulate around the heart. Cancer and other conditions, we're talking about trauma tonight, but other conditions can more slowly build up fluid around the heart. But in this setting, we're concerned about a thing which I'll show you on another slide called Beck's triad, which is distension of jugular venous veins, which I'll show you in a moment, shock, which is low blood pressure, and muffled heart sounds. I'll show you that in a moment. An acute pericardial tamponade is a sudden fluid accumulation, and the pericardium around the heart cannot stretch. It cannot adjust, with a dramatic increase in pressure inside the sac around the heart, such as by chest trauma or a ruptured aorta or a ruptured ventricle after a heart attack. And so in that setting, we can see compression of the heart muscle by fluid, in this case, blood that is building up within the pericardium, a sac like canvas around the heart. It prevents the heart from filling. If the heart only pumps out what it gets back, and if it cannot fill, it has nothing to pump out. This is what distended neck veins look like. These are enormous distended neck veins here, going all the way from the clavicle, that is right here, all the way up, in this case, really to the base of the ear. These are enormous, and you can actually see the blue color of the venous blood in this case. In the setting of a cardiac tamponade due to trauma, we would see distended neck veins. Because there is blood around the heart, when we put the stethoscope on the heart, we can't hear it so well, and thus the heart tones are muffled and low blood pressure is present, which we call shock. There also can be bleeding into the pleural space, which is where the lung is supposed to be. Causes include trauma, like this guy with a knife in his back. It can occur at surgery. For example, we try to put in a chest tube. And there are many other reasons as well, such as a rupture of an aorta, cancer in the chest, causing bleeding of a cancer and so forth into the chest wall. Hemothorax is the most common result. Blood inside the chest is the most common result of a major chest wall trauma. And the incidence of a hemopneumothoraces, which means a collapsed lung plus blood in the thorax with patients with rib fractures alone, think car wreck or a fall, is as high as 30%. And so thus you will have blood in the pleural space due to bleeding from the major central chest vessels, but occasionally just the vessels in the ribs themselves. We call it between the rib. That term is intercostal. Between the rib can bleed enough to cause a large amount of blood. So what do? We take a guy like this with penetrating chest trauma to his posterior chest. We will start an initial survey. We will do a chest x-ray. We will determine if the vital signs are either stable or unstable. And ultimately we will move on down possibly to the operating room where we will do some sort of approach to the chest, i.e. we will cut the breastbone, the sternum open, or we will cut the ribs open in the operating room, or if the vital signs are stable, we may observe the patient. And just to give you an example of what the heart and blood vessels look like inside the chest, you can just see how enormous these vessels are under high pressure. Imagine a knife hitting those vessels inside the chest wall. I include this picture to let you know, ladies and gentlemen, that we're all very, very human. I want you to look at this picture for a moment. Most of you have never seen this before. Every single thing in this picture was a moment in an attempt to save a patient's life. Every single thing was a moment in that patient's life to try to save a life. And you can imagine the near chaos that's going on in that room, I should say, at a frenzied pace in a controlled manner. But imagine how we feel after that when we come back to this room. We've got the patient off to the operating room. Who takes care of us after a scene like this? We get them up into the operating room so that hopefully in a controlled manner, Brandon gave that wonderful talk about the resuscitative hysterotomy and then taking the woman to the operating room to attempt to save her life, where with the skill of the guided hands of the surgeon that we can try to restore life where perhaps there was none. So maybe this guy can now go off to college, finish college, and get on with the rest of his life, or perhaps not. Welcome to medicine, ladies and gentlemen. These are the difficult decisions that we have to make every day. The chest, then, is a very complicated place. And by the way, people should stop fighting. All right, Brandon. Elaine, are you up next? Let me unshare here. Let me see if I can figure out how to do this. Let's see. I'm trying to unshare here. Stop sharing. That's what I need to do. All right. Brandon, Elaine.
Yeah. Dr. Reno will take over. And then Kiana will bring it home. You have a co-host, I see.
I do. This co-host is asleep.
That's so sweet.
Do we want to do mine at 7:30? And we told the students we'd have time for questions. If we want to do it another time, we can do that too.
Let's take votes from the students. Who wants to hear her talk, or who wants to go straight to questions?
Yeah, I saw her case. It looked good. Yeah, they want blood and guts.
Blood and guts, Elaine. You got it, baby.
I picked a cheerful case.
All right, here we go.
Terribly uncheerful, but oh, did I wake you up by talking? Okay, let me screen share. All right. Can you guys all hear me?
Yes.
Yes, ma'am. Just right. Just right.
This is a case I had when I was a resident, and I will tell you I've changed a lot of it, both for educational purposes and to protect the patient's privacy. But I remember this case like quite distinctly. if she starts losing it, I'll send her to my husband. So, so disclaimer, everything that's identifiable has been edited, including like age, gender, things like that. So, case presentation. So when I was a resident, we did what's called an EMS rotation. So we were riding along with the paramedics to kind of see what they do in the field and learn about them. And I remember this event very distinctly. So there were multiple 911 calls that came in that a car had come off the road, flipped, and was submerged in the river. Location, it was Colorado. It was winter. The water was cold and freezing. Sorry, it says case 2, but it's actually, I thought I was going to go second, but I went third, so it doesn't matter. As we were getting there, the fire department arrived on scene first, and they found 3 people huddled on the side of the river, and they were reporting that there was a 4th person in the car still, and we, the paramedic group, was en route. So I was a 3rd-year resident riding along with our paramedics. Our scene, this is not the scene, but representative, the bridge was about 15 feet above the fast moving river. The water was above freezing, but not by much. The river was about 10 feet deep, and there in the middle of the river was a partially submerged car upside down with the wheel exposed. And there were a whole bunch of people who had stopped their cars and were standing on the bank of the river, not sure what to do. So we got on scene, and by that point, the firefighters had swum out to the car. They found the patient. Fortunately, she was still in the car. She hadn't been swept away, and they drug her through the water to the shore. So what do you guys do next? Trying to figure out how I can see my screen and the comments.
We got one person saying CPR, check pulse, check ABCs, ABCDEs, check for responsiveness, check breathing, get her warm.
Yeah, so you start at the basics, like we always talked about, airway, breathing, circulation, disability. So they drug her out of the river onto the banks, onto a hard surface. And we got to work right away. So her airway was filled with water and mud. She was not breathing. She was pulseless. And laying on the side of the river, we intubated her and we started CPR. So what do you think is your differential diagnosis for her cardiac arrest? Why did she code? What are the big things that you're thinking of right now?
I see hypothermia, hypothermic shock, trauma, hypothermia, lots of votes for that. Drowning,
Yeah.
trauma.
So those are kind of our big 3. So, and we're thinking about this from a multimodal approach, right? A lot of the time when you have a cardiac arrest and trauma, it's straightforward in that you're thinking, you know, what's happening? Like, is it a head bleed? And the head bleed caused cardiac arrest? Is it a collapsed lung, a tension pneumothorax, like Dr. Fowler just talked about? Do we have intra-abdominal bleeding, and is a patient hemorrhagic shock? This case was extra complicated, right? Because not only do we have all of the traumatic causes of cardiac arrest, but this woman was upside down in a car in a river that's freezing. And so it could be hypothermic arrest, it could be that she drowned. But the thing about field care of all these patients is it's always the same, right? A, B, C, D, E. So it doesn't, in some ways, it doesn't matter which of these is our underlying etiology, because we're kind of going to proceed the same. So how do you manage on the scene and on the ambulance? So, you know, the patient was being bagged as we prepared to intubate. The fire department started stripping off her wet clothing and throwing warm blankets on her and performing chest compressions. We got IV access and they started fluids. And then, just like we talked about, immediate transport to a major trauma center was planned. And so the trauma center was notified, hey, we're bringing in an MVC drowning victim, and there's a lot going on, and, you know, we're we're headed your way, so be ready. You know, we get the wet clothes off and we get blankets on her. We got her on the monitor and we did a rhythm check, and her rhythm was a PEA, so pulseless electrical activity. She got epinephrine, and she's getting CPR. And, you know, once we kind of got our basics going and got CPR going, we started rolling. And I will caveat that in a lot of instances, EMS stays on the scene when CPR is going and continues to run resuscitations on the scene. But that applies to, you know, like the 75-year-old chest pain patient who had a cardiac arrest. In instances where you're worried about hypothermic arrests or trauma arrests, those are the patients that people start to move faster, because the definitive care for those types of arrests is really not going to be managed well on scene. And every EMS group has a different protocol on how they manage this and kind of the thought process around this. So we got the patient to the emergency room, and she essentially came in pulseless, apneic, and after about 10 minutes of CPR, her core temp was 33 degrees, so not cold enough to cause her to code. And essentially right as we're pulling in, we got pulses back. And her initial rhythm strip just showed sinus tachycardia. So ongoing ED care, this is not her photo, obviously. It's not even, it's a representative photo, and it's actually been published. You can see it at the bottom. So, you know, the ED, just like the crew did in the field, goes back to the basics. And so they start head to toe. So they look and make sure the tube is in the right place, right? You need your tube in the airway. You need to make sure it's not in the esophagus. And after your primary survey, people started, the team started a secondary survey. Hi. And with the secondary survey, they found a seatbelt sign. Hold on, I'm going to pass her off to my husband. So what do you guys think is a seatbelt sign and what causes it?
Nothing in the chat yet. A collision causes it, a contusion, yep. Pressure, blunt force against the seatbelt, blunt force from the crash. Could be internal bleeding from the force. Yeah, they're dancing around it.
Yeah, so that's, you guys are getting there. So essentially, right, in a major trauma, the patient is getting thrown around and they're thrown up against the seatbelt, and the seatbelt locks and catches them. And so you get bruising on the outside of the body. And it's not that the seatbelt sign itself is dangerous, right? You're not going to bleed to death from the seatbelt sign. The problem is that the seatbelt sign is, to us, it's a red flag. And it's a red flag that there's an increased likelihood of major traumatic injuries. So injuries to the neck, to the chest, to the lumbar spine, to the abdominal organs, and to the mesentery. And actually, if you look at the literature, and if you guys are super motivated, if you cut and paste that link, it'll pull up a paper that's open access, which means you can read it. It's not behind a firewall. It talks about what is a seatbelt sign and what does it indicate. But to us, it's a red flag that we need to remember. There's an increased likelihood of intra-abdominal or inner thoracic injury. So one of the first things we did, and we do in trauma patients, is we did what's called a FAST. So a FAST stands for Focused Assessment with Sonography for Trauma. And we look in the abdomen. We can do what's called an EFAST, where we look in the chest as well. But we look in the abdomen, and we look kind of at critical places where we know you can bleed to death. And so we start in the right upper quadrant, and we look between the liver and the kidney. And if you can see bleeding around the liver, which is one of the common things that bleeds in trauma. Then some people go to the pelvis first, some people go to the left upper quadrant. I tend to go over to the left upper quadrant, and you're looking at the interface between the spleen and the kidney, because these are kind of your big bleeding sources in trauma, and you're looking for fluid. So if you look at this photo, so the organ is gray. This is the spleen. This is the kidney. This is diaphragm and tissue, and then blood is black because blood is fluid. Urine is also black, but you're looking to see fluid where you shouldn't see it. And in this instance, what you're seeing is the spleen is floating in fluid. And that is very concerning because it indicates your patient's bleeding. We also look in the pelvis, and then we look around the heart, and you can see fluid in the sac around the heart called a pericardial effusion. You can also look at the lung field, and you can see if you see lung slide or not. So this is, again, not in any way the patient's photo. Obviously, this is a published photo, but we saw fluid around the spleen. And so then we kind of step back and reassess, okay? So we did what's called a big two. So the patient got a chest x-ray and a pelvis x-ray performed, and you're looking for collapsed lungs, you're looking for evidence of multiple or specific types of pelvic fractures that can make a patient what we call hemodynamically unstable, so evidence they're bleeding. So in this patient, her big two was normal, so no lung collapse, no pelvic fractures. Her chest x-ray showed clinical concern for aspiration, right? Which you kind of expect, because at this point, she was down in a car in a freezing river. And then when we reassess her, her vital signs have changed a lot, right? So she's still cold. Her heart rate is tachycardic. Her blood pressure is improved. She's satting about 90% on the vent. So I will caveat, in Colorado, none of our patients are 100%. Our patients all like hang out around 92 to 94%, just because of the altitude. So 90% is really not that low. I mean, I have patients come in that live at 90% all day, every day. For a young, healthy woman, that's lower than I would expect, but it's not, say, 90% in, I don't know, Miami, Florida. It's 90% in Denver, Colorado. So where do you want to go from here? What do you guys think? And this is a little bit controversial, and some of this depends on who your trauma team is. I can't see the chat still.
Somebody's saying needing to work on getting her warmed.
Yeah, definitely. We're still working on warming her, and cold trauma patients are bad because cold makes you coagulopathic. So if you are cold, you bleed more. So the trauma team felt like she was more hemodynamically stable, and they wanted to know what was going on. And so they took her to the CAT scan. And this is, again, not her photos. This is published representative photos. But it kind of shows evidence of what you see on ultrasound and then what you can see on CAT scan. And so this patient was found to have a large splenic laceration and was bleeding. And so she went to the operating room. They removed her spleen. The good news is, with some extra vaccines, you can live for the rest of your life without a spleen. You need some vaccines to protect yourself against encapsulated organisms, but solvable problem. She went to the SICU while she was intubated. They started weaning her sedation, right? Because we still don't know why she had a cardiac arrest. Like, we don't think now she was super cold. We don't think it was hemorrhagic shock because she seemed to stabilize once we got pulses back. At this point, the presumption is she arrested because she lost her airway, and she lost her airway because she drowned. One of the, I guess, upsides is the wrong way to phrase this, but there's a lot of literature on post-cardiac arrest care and hypothermia. And this is also heavily debated in the medical literature, whether they need to be cold or whether we just need to avoid fevers. But after patients have cardiac arrests, we often cool them to protect the brain. In this instance, she sort of self-cooled, right? Like, she drowned in a river of freezing water. And so her sedation was weaned. She was responding nicely. Actually, she was able to be extubated. So ET tube was able to be pulled. She was able to be taken off the ventilator. And actually overall, she did well. And she left the hospital about a week after this event, like walked out all by herself, did absolutely fabulous. And so I love this case for a number of reasons, because I think it talks about like, so the interface between all of the services, like this patient would not have survived without every crucial member of the chain involved, including the fire department members that like saw a car upside down in the river and a missing person, and at no point were they like this is too dangerous, which we always teach them scene safety, but and they literally just like powered in the river and found her and drug her out and swam her to the shore. And then because we needed more hands on deck, like they stripped her down, and then they were in the back of the ambulance. They stripped out of their wet clothes because it's winter in Colorado and it's cold. And literally these guys were like in their underwear and a t-shirt doing CPR while we transferred her to the hospital. I guess they were in kind of their fire underclothing, but whatever, because we needed all hands on deck to do good quality CPR while we moved her. And then the paramedic crew that was like, you know, we're laying on the side of a river, like getting an airway in this patient. It's like pitch black. People are shining their cell phone lights so we can see better. There's like 20 people who've pulled off the road now and are all like watching this. Unfortunately, it's too dark for them to like record YouTube videos. But watching this happen, and then the ED team that like the moment we got there, they're like, we're ready. You know, we have the trauma team, we have an operating room ready, we have the anesthesia team ready, like, you know, like bring it, we're ready to go. And so, and the final outcome for this patient was great. And it, you know, I feel like if any key step in this chain had not occurred, like it would have been totally different, right? Like anyone who had dropped the ball or even just not been at the very top of their game that day, like it would have been over, right? She would have just drowned in the river and that would have been the end, and it would have been a tragedy. But so these are the cases in EM, I think that like I've, you know, this like incredible level of teamwork where like everyone is just like, I'm here, I'm ready to work, like it's go time, and every single piece falls in place. And as a team, like every link in the chain links up and you can do something fantastic. And so I picked this case for that reason, because I think it's just like such a great example of care that, you know, such a big difference in her outcome. So that's the end of my case.
And that's a great case. And I'm actually really glad that you went third, so we can end on a happy note.
Yeah, your guys' cases were less cheerful. So,
all right. So, Kiana, we'll let you bring it home. If Dr. Reno, if you want to stop share, and Kiana can bring up the last couple slides. And guys, I know it's you know, we're coming up on just 10 minutes left in the period, but we'll stay on as long as you want to answer questions and then tell you about the quiz and let you get on with your night. So, Kiana, shoot.
Yes, give me 1 second.
Okay. And just speaking from experience, you haven't lived till you've resuscitated somebody on the side of the road in your underwear. It's a special moment.
Well, I mean, it was cold. It was really, really cold. Like they had to get out of those, you know, the pants they wear are like.
Yeah, those turnouts.
Yeah, I don't know what they're called, but they're heavy when wet.
Yeah.
So.
Brandon, that does raise the issue about you on the side of the road in your underwear, but in the interest of the students, we won't go there.
You'll never find that video. I paid good money to have it removed from the internet. Well, Kiana, while you're pulling it up, I've got some of the questions here. I'll just start kind of going from the top. So someone asked about regarding the resuscitative hysterotomy. and fast decisions. How do ED doctors make a decision or act quickly in a high pressure situation or when the patient is critical, especially if you've never done it before? So that's a great question. And again, that's the reason why your residency training is 3 years, and you spend a lot of that time practicing these procedures. Now, you may not see it in real life, but there are certain metrics, so to speak, that you have to meet to be able to graduate from your accredited program. Sometimes you're in a simulation lab doing high fidelity sim or poor man simulation. But either way, the first time that you're doing something of this magnitude, the first time you need it to be done is not the first time that you should be doing it. You should have had some reps in on simulation or some other mechanism, and you practice with in residency. That's kind of what the training is for. You good, Kiana? You want me to go with another one?
I'll keep going.
Okay. Let's see. So another one asked specifically about the EMS career. Can I go into more detail about that? Were there periods where I relied on my paramedic skills to treat a patient? And I think that as far as the paramedic skills coming into medical school and then into my training, there's probably two big advantages. Number one is it gave you the experience and the repetitions with managing critical patients and feeling comfortable and competent and confident with that, and being able to kind of lower the anxiety in the room or on the scene and just do what needs to be done. And I didn't have to have that same learning curve as a medical student or an intern as some of my colleagues did. Now, that being said, after about a year or so of them also doing it, we were kind of at the same level. The other advantage that I think a career in EMS gave me was I was much more comfortable actually talking to patients and developing quick rapport. I'm in their house and I'm a complete stranger. I don't know them, they don't know me. And suddenly within 30 seconds, I'm in front of them in their house in their most vulnerable state, asking them very detailed, important, intimate questions. And you have to develop a quick rapport. And I think that was another reason that I didn't struggle as much at the beginning of medical school and residency, because I had already overcome that learning curve. But like I said, most of my colleagues also overcame that learning curve. I just had a bit of a head start. But I was also a non-traditional student, so I cheated.
Hey, Elaine, we have a question. Let's see. Ask on an out there topic, since you're holding your young in there. What was it like being pregnant while being an ER doc? She's really curious.
Yeah, that's a great question. So my husband has she fell asleep during the presentation, so now she's in bed. I think my husband's rocking her and giving her a bottle. But so that's a great question. So the first I would say to all the women out there in this group and anyone who wants to be a parent, like, it is definitely very feasible. There's actually a very famous Facebook group called PMG, and it's called Physician Mom Group, and there's 75,000 women doctors in it from all over the world, and every specialty, like, everyone's making it work, and we talk about how to make it work, and like we talk about kind of our individual struggles. It's probably the best use of Facebook I've ever seen. But how did it feel to be an ER doc while pregnant? So the first is there's some risks that are associated with it, which makes it stressful. So I was, 5 weeks pregnant with Caleb, and I got an email that my patient had meningitis, followed by an email that I'd been exposed to disseminated zoster, followed by an email that I was exposed to tuberculosis. And I was like, just make it stop. Because all of those are high risk things in pregnancy for concerning outcomes related to the mom. There's also some data that shows that ER docs or night shift workers have an increased risk of miscarriage and then an increased risk of preterm delivery. So what our group does is, if you are in the third trimester of pregnancy, you don't work nights anymore. You're switched to all days. And I will say, I was so ready for both babies to come early. And by the end of every single shift, like because of being on my feet for 9 hours and because of like not drinking enough water, by the end of every shift by sign out time, I was contracting. And I'd always have to like stop and catch my breath during contractions, but they were never effective enough to make me go into labor. Both children were like probably gonna, I don't know, be happy to be in there till they went to college. Like neither one was remotely interested in coming out. So I had to be induced both times. But I think groups are like taking risks or making things to help protect pregnant women. But at the same time, like I would absolutely go for it. Every single ER doc woman I know above the age of 40, I think has kids, and like we all made it through, and it's definitely worth it. And I think being an ER doc and a mom is an absolute great career because like I get to have a lot of time with the kids during the day, especially when they're young. And other people like go to work 9 to 5, and I get to spend those days with my kids. So I think it's fabulous. But
And then I think a good question to end on is, how do you guys think EMS has played an impact in how you associate with patients, like from what you've learned from past experiences?
I kind of gave my answer to that one already. And so, I just talked about how it helps me be much more comfortable with talking to patients and developing quick rapport, and then being very comfortable with emergencies. But I mean, I did it for 12 years before I did medical school. So like I said, I cheated.
Okay. Well, I think that this was a great session. And if you guys are still here, please send love to Dr. Fowler, Dr. Machete, and Dr. Reno, and I will put up the quiz QR code. So this will be due next week at 6:59 p.m. Central Standard Time. So please be sure to download your certificate afterwards. And if you have any questions, please feel free to reach out to us at any time. But thank you, providers, so much for dedicating your time to the session.
Dr. Fowler, any closing thoughts?
Only to say thank you so much, Brandon. Thank you so much, Elaine. Kiana, thank you for taking the lead on putting this together. We have another session tomorrow night, right, Kiana? And another one Thursday. Is that right?
Y'all are going to get sick of us.
You guys are getting saturated. I spoke with an admissions committee person yesterday, and it does sound like that the colleges and the medical schools are beginning to pay attention to these virtual shadowing hours. So we're going to keep coming back if you keep coming. So
someone's asking why this week. We just have a couple makeup sessions that got scheduled this week. So we're playing catch up with some speakers that weren't able to do it before.
All right. So on behalf of the whole team, we want to thank you for coming. Appreciate the working group being out there for us. And again, Brandon and Elaine, thank you so much. And we hope you all have a great evening. And with that, we wish you a good